starts. All right. We talked previously about neonatal asphyxia, and this is the reason why we're doing the resuscitation is because there's that presence of hypoxia, hypercapnia, and acidosis present. Left if you don't fix it, the child's going to end up having severe brain damage or damage to other organs. We know it can be caused with something on mom's end. If mom goes into cardiac arrest at the time of delivery, that can translate into asphyxia for the child. It could be something wrong with placental blood flow. That cord is wrapped around the child's neck or is being compressed. It could be an insufficient umbilical blood flow as far as from mom's side of the picture. And it can be problems with other fetal developmental disorders that are present that lead to the asphyxia. If you take a look at of the 4 million births that occur, roughly 7% of them are low birth weight, which that would be considered under 2,500 grams. Very low birth weights are a little over a percentage. They're about 1,500 grams. I don't really care that you know the percentages, but I would like you to understand that less than 25 is low birth weight. Under 1,500 is very low birth weight. And these are, obviously, as the birth weight goes down, the risk of needing resuscitation goes up, and there's it's typically due to prematurity that this is happening. And fortunately, only about 1% require extensive resuscitation. Most of them can just get a little bit of support to get them over the initial first few minutes of life. 4 steps that are there: preparation, stabilization, assessment, and resuscitation. The preparation really, as I said, mentioned earlier, was a team approach. Everybody is responsible for everything. It's not just one person who is responsible for making sure the laryngoscopes are there and they're functioning fine. We definitely are going to need equipment that can maintain warmth. One of the key facets after birth in that transition from intrauterine life to extrauterine life, it's damn cold outside for them. They're used to having this nice warm environment, and they get dumped out into the middle of nowhere, and oh my gosh, is it cold. And that cold, especially in prematurity, is a huge stressor. And you also need to provide and maintain an airway, obtain vascular access, and provide resuscitated drugs in those individuals that aren't responding to conventional measures. We talked about those high-risk deliveries previously. Those are the children that we're probably going to be a little more on guard for having to resuscitate, because mom born to a first-time pregnancy who has placenta previa. You know that's going to be a problem as far as managing the delivery in the process. At a minimum, we want to know if preterm labor is present, the approximate gestational age of the infant, not that we can necessarily say for sure, but gives us an idea. Are we dealing with a 32-week or are we dealing with a 37-week? Big difference in how that baby is managed. The number of babies, if there's multiple births present, we want to be aware of that. And then also if meconium is present in the amniotic fluid, that tells us that we might have a child that's at a higher risk, especially for aspiration. So that's preparation. Stabilization means that we want to place the baby once they're delivered into the proper position. And the proper position is where the head is neither flexed nor hyperextended. Unlike the adult, where we like to have them hyperextended, we want them basically in a neutral position. When you hyperextend an infant, that cricoid cartilage actually starts to kink. It starts to become an obstructive element at that point. 3 initial efforts then for a child who was born in normal vaginal or C-section delivery: drying and warming. So we want to get them dried and warmed as quickly as possible. As we'll find, the fact that they're wet in and of itself is enough of a heat loss to the child. We want to establish their airway and maintain it. So if they got they have a big head compared to the rest of their body, so the tendency to lose that airway once they're proper positioned is increased. And then we want to stimulate them to begin to have them cry and breathe in a normal fashion. We want to we prevent that heat loss and stimulate respirations by drying thoroughly, removing the wet linen, as I mentioned, repositioning the head and giving them some stimulation to be able to breathe. Often just the drying of them is enough of a stimulatory mechanism to begin to have them breathe on their own. One of the goals, as we mentioned, was this thermoregulation, maintaining a neutral thermal environment. Anytime a neonate, especially premature neonate, becomes cold, that's a huge stressor on the system. Ordinarily, we can maintain our body temperature in a homeothermic state pretty easily, and core temperatures do not vary by much. It's not quite the story when we're first born. There's a real delicate balance between the amount of heat that is produced and the ability to maintain a core temperature and the heat which is lost. Under ordinary conditions, we end up having vasoconstriction happening. That's why you end up having the heripulations, where you get the little goose shivers on your skin. It's due to that vasoconstriction of the blood vessels. That leads to a reduction in blood flow to the skin. We have, in many cases, some of us have more than others, a lot of subcutaneous fat that surrounds the internal organs that helps maintain that heat of the core organs themselves. In the case of babies, however, there's a substance called brown fat that, when broken down, is a mechanism by which heat can be created. It's called non-shivering thermogenesis. So they burn that brown fat to be able to create heat. The problem is that it doesn't start coming along until about the 26th to 30th week. So if you're born at 25, you don't have that fuel available, you're going to very quickly succumb to cold and end up having a world of hurt. By the time they're 34, 35 weeks, nearing normal gestational age for birth, then you have a sufficient amount there to be able to survive that first few hours. Disappears shortly after birth, and where it's located is around the great vessels, the kidneys, the scapula, nape of the neck, and the axilla. And when you're hypoxemic, that ability to use this as a fuel goes down. So it's one of the unique things that babies have that allow them to maintain a neutral thermal environment, is that they have brown fat metabolism going on, also known as non-shivering thermogenesis. There's a gradient that exists between the body core and the skin, and then between the skin and the environment. You can see there's a difference between there, so you can get heat loss across the skin through to the environment, which is going to ultimately track itself back to a heat loss from the internal organs to the skin. Whoops, let me do that. We end up having heat loss through sweat, through the vasodilation, where ordinarily you want constriction to maintain the heat. It's the environmental factors that we're going to focus on, because that's a key area where a lot of heat is lost. And obviously, these kids have a much higher body surface to mass ratio compared to adults. So any amount of heat loss is going to be manifested quite rapidly. And the four factors, question?
Is the body surface to mass ratio something that we should?
No. Well, just understand that they're not just little adults. That functionally, they're different. And because that body surface has such a higher square meters compared to their body mass, they're going to lose heat quicker. So we're really putting them at a disadvantage, is the bottom line with that.
Proportionally, their skin is a lot bigger organ compared to an adult. Is that what we're saying, kind of?
Yeah, especially as it affects the heat loss. A small drop in temperature to us is not going to be a big deal. To them, it's huge. 4 ways that we have heat being lost. We covered this back, I think, in 1060, but it's good to review it. Radiation is the movement of heat from the neonate to a cooler object that surrounds the patient but is not in direct contact with them. So the sun coming in is a mechanism by which they can be heated. The walls of the incubator are very thick, so they end up having heat not being able to be lost by being radiated outward. Air conditioning units, windows, those are all examples of where heat can be lost or gained one way or the other through radiation. Conduction is basically where there is a transfer on a direct contact. So if I take a baby and I put them on a cold scale, or I put them on a cold mattress, or I leave those cold sheets on or towels after I get done drying them. Note, if you go back and look at that slide, we dry them and we take the towels and get rid of them and put some warm stuff on. Because that cold substance or cold thing that's touching the baby is enough to have transfer of heat off of the baby into the cold object. Heat always moves, or energy always moves from the heated object to the cold object. Convection is the movement of heat due to air moving above the surface of the skin. This is how things like wind chill factors are calculated. Where we see it is just having that child lying on a warming surface. The air of somebody that is created by somebody walking by is sufficient enough to cool that baby down. So if you look at a warming tray, what you end up seeing is the baby's on the tray, and the sides actually have walls that fold up so that there's not that loss of heat. In fact, what they can also do is take and just put cellophane over the top of that, so you basically have a cover over the infant. Even the simple mechanism of delivering some oxygen by holding a cold flow of oxygen near their face can trigger some heat loss there. And the final one is evaporation, and that just as the liquid changes to a gas, it evaporates, it also removes heat from that source. So we'll see that not only in the respiratory the pseudostratified ciliated columnar epithelial cells, but you also see it on the skin. So that's why we want to get that kid dried off as quickly as possible to reduce the amount of evaporative heat loss that is present. So, we talked about drying them. We put them in radiant warmers, just like a big boy where you got to keep your Slim Jim warm. You put it under a light. You put the baby under a light to be able to maintain heat. Often they'll have a cap on. They'll wear a little hat because it's cold outside. Keep them warm. Any mattress or incubator that is there should be pre-warmed, so you're not taking and allowing that child to be any degree of heat losses from coming in contact with that. Pretty much a neutral thermal environment as far as their skin temperature. I mentioned about the incubators being double walls so that it's like double pane glass, you don't lose heat as much. Cellophane or aluminum foil over the surface of the radiant warmer just to maintain heat. Location of the incubator, don't want it by a cold window because you'll have heat transfer there. And oxygen flow turned off, and we're going to heat and humidify anything we're delivering. So most of the heat production that ends up happening is through that metabolic process. We talked about the brown fat. Infants, especially premature infants, don't shiver as much. They generate their heat through that non-shivering thermogenesis. Assuming they're old enough to have some brown fat present. And then just muscle movement is going to end up having some heat production also. We talked about the surface area to mass ratio being a whole lot larger. That's one of the reasons it's hard to maintain heat in these kids. No subcutaneous fat, no internal fat, so that transfer from heat loss internally to the skin is quite substantial. They don't shiver, mentioned that. Thin layers of skin compared to older people. They don't have as much caloric intake in the initial phase because they haven't been eating much. And especially in premature 24, 25 weeks, that brown fat just isn't there. And unfortunately, especially when they're in the NICU, you need to handle them, you need to expose them. You open up that warming tray, and you now have basically exposed them to some of the cold. So we try to minimize that. You don't need to. I'm not going to ask you a question about this. Just 36 to 36.5 is the temperature that we're striving for. And a neutral thermal environment is basically where the metabolic work is and oxygen consumption is at its lowest that it can possibly be. And this is what the radiant warmer looks like, and I don't know if you can see this really, really well or not. But there are little walls here that are up, and that prevents that convective loss of air moving across. And this is where I was talking about taking a piece of cellophane and just placing it right over the top to maintain the heat on the inside. And the heat source obviously is right up here, going down. And there's a incubator. A little bit harder to manage the child because you can't get as direct access with them, but it is a mechanism that is utilized. And you can see the double walls that are there to maintain the heat. This is taking some aluminum foil and putting it so it reflects any heat that is radiated off of the child, reflects it back inward. It's an ugly looking kid. Oh, gee, it's a dot. There's my cap. Keeping baby's head warm. Bald little heads, we lose heat more often through that. And the problem why we do this is because any increase in any cold stress that exists increases the oxygen consumption of the child, which is going to reduce their amount of oxygen that they have available elsewhere, and that combination of hypoxemia and acidosis is a bad combination to have extrauterine as well as within mom. They also then deplete glycogen stores, and their blood glucose falls. If not treated well, it can end up leading to an inability to gain weight. And there's often frequent apneic periods that exist in these kids. So you can see why the incidence of cold stress is something we try to avoid at all costs. Okay, so we got the kid warmed, got him dried off, took the cold stuff through it, put him on something that's warm there. Once they're positioned, we clear the airway of secretions, and we always do it by suctioning the mouth, followed by suctioning the nose. How do I remember that? Well, M comes before N in the alphabet, so mouth has got to come first. We don't want to do harsh suctioning because they actually have some vagal receptors that are present in the mouth and nose that can end up triggering a bradycardic episode. If meconium or blood is not present, we suction with a catheter. A little bit inside the lips for about 5 seconds. If meconium is present, totally different avenue is followed where we end up actually intubating or attempting to place an endotracheal tube into the trachea with what is called a Meconium Aspirator. And we try to not stimulate the baby as much as possible. So in that drying process, we're going to be very cautious about how much stimulation we do, because the last thing we want them to do is when they're stimulated is breathe it in. Exactly. This is what a Meconium aspirator looks like. It fits on the end of an endotracheal tube, and it's basically just a suction apparatus. So I'm using the endotracheal tube as a suction catheter. Okay? And able to remove as you go. Kind of a yonker for babies. There you go. Always suction before stimulation if meconium is present, and we attempt suctioning before we ever do positive pressure ventilation, because that meconium, if it is aspirated, we certainly don't want to blow it further down into the infant. There's what's called a ball valve effect, where on inspiration it can get around any obstructive present, but on exhalation it can't, which traps the gas. A subsequent breath, we're putting more air in, can't get it back out again. Eventually, you end up with some pulmonary barotrauma. Okay? So meconium aspiration syndrome is treated totally different than it is with, let me rephrase that. In the presence of meconium staining at birth, we treat that patient differently than we would just a normal, ordinary birth as far as stimulation. We talked about the lungs being very, developing later, one of the later organs to fully develop and be functional. So premature babies, somebody born at 26 weeks, are going to have less alveoli present and have problems with gas exchange. They also have a very poorly developed neurological system. So premature babies don't often respond to the change in environment and breathe in a normal fashion. When they're not responding to the extrauterine environment, and we would notice that by having a strong cry, good respiratory effort, moving all the extremities, we need to do something to go ahead and stimulate them, and we do things like flicking the soles of their feet, one of these little things, rubbing their back, drying with a towel. All those things will begin the stimulation process. We don't slap them, we don't shake them or spank them or anything that, they do in the movies. If they are in an apneic situation, stimulation should respond or should cause a response in them as far as them beginning to breathe. We're going to talk about primary apnea versus secondary apnea in a bit, but primary apnea is an apnea that's primary. Secondary means that they were apneic in utero and now they're apneic again after birth. And there's a difference between the two of them. The secondary apnea is not going to respond to stimulation. The problem is you don't know which it is because you're seeing it for the first time, not knowing what went on in utero. Okay, so here's you got the flicking of the feet, rubbing of the soles of the feet, rubbing the back. Those are all things you can do to stimulate the baby. Then we want to get into assessing them once we got them stabilized, got them dried off, got them positioned, got them suctioned, got their airway cleared. We want to go ahead and assess them. We're primarily looking at the respiratory efforts, their heart rate, and their color, and using that to decide what to go on from there. And there are some algorithms. I think I'm going to stop there. Okay?